This is the Mike LiPetri Show. Dr. Larry, welcome to the Mike LiPetri Show. I love that name, Dr. Larry. Dr. Lawrence Eisenstein. Did I pronounce that correctly?
You did.
I love it. Former Nassau County Health Commissioner and Catholic Health's VP and Chief Public and Community Health Officer. Welcome to the show. Thank you so much.
It's my pleasure to be here. Thanks for having me.
I love it. Dr. Larry, how did that even come to roost? Can you tell me about that?
Yeah, it's funny. When your name is Lawrence, people typically just start calling you Larry. But when I was young, my mother was adamant. I named him Lawrence. You call him Lawrence. And then one day, people just started calling me Larry, and I wasn't going to argue. Okay, it is. And then, so that's how I would introduce myself. And then with the pandemic, by that point, County Executive Laura Curran was running Nassau County, and I was the Commissioner of Health. And I'm lucky. I had 4 county executives that I worked under. The first one, County Executive Swazi, I was Deputy Commissioner, but all of them were respectful and good to me. And when the pandemic started, and all of a sudden I'm on TV every day, live with County Executive Curran, when they would ask a health question, she would just start saying, well, Dr. Larry's here to answer it. And it became... We did over 100 straight days of live press conferences with the same reporters and the same group of people, and it just became, that's who I was, Dr. Larry. and it stuck.
Yeah.
People still call me that. So it was just not something I asked for, but something it just happened, and it was kind of charming.
Do you have people, like when you go around and travel anywhere, do you have people like saying Dr. Larry or anything like that?
So during the pandemic, anywhere I would go would happen. It would I have teenage daughters, drive them nuts. We'd be at a restaurant. One time at a supermarket at midnight, somebody saw me scream, "Hey, Dr. Larry!" And I waved back, and my daughter said, "Who's that?" I said, "I don't know." But my daughter's in college at Penn State now, and we went to a football game this year. So now it's a couple of years into this, and I hadn't been on TV every day for a while. This was in the fall, and I was wearing a Penn State baseball cap and a sweatshirt. I didn't look like I'm in Dr. Larry mode. And we're walking through this massive tailgate, and the party is miles long, and with my family and my daughter and some friends, and all of a sudden some guy in front of an RV tailgating screams, "Hey, it's Dr. Larry!" And I looked up, and he says, "You don't know me, but you're my hero. I watched you on TV." And my daughter rolled her eyes, and my wife said, "We got to go to the game." And he said, "We got filet mignon." I said, "I think we should join that party." But for a while, now once in a while, most recently I was in a bagel shop, and somebody said, "You were that doctor from Nassau County." I said, "Yeah, but it's happening less and less often." But it did. It was fun for a while.
Yeah, it was fun for a while.
Yeah.
I remember I had that when I was as an assemblyman.
Yeah.
You constantly have it where it's like, "Hey, Mike." I'm like, "Oh, man, do I know you? Do I not?" Like, I feel terrible if I do know you and I don't remember. So I can only imagine with yourself, too, as being on there. How many, 100 days straight was it?
More. It was something like 121, something like that. Yeah, where we did live press conferences. Right. And then after a while, it was once or twice a week. But, you really... it was like going to battle together. It was
well, ever changing. I mean, during the pandemic, especially the early months. I mean, that was just every single day was something new.
Yeah, it was one of the concepts that was hard to get the public to understand. We were not inconsistent. We were just learning new things. And if you look back at the earliest press conferences, I said, "This is the best information I have today.
Right.
This is new." Now, I'm an infectious disease specialist by training, so the concept that a virus would do this was not surprising to me. It was the impact on society was something we haven't seen. So it was disturbing and very impactful. But in infectious disease, we train for this. We expect it. Quite frankly, there will be another respiratory virus that causes a lot of damage and destruction and unfortunately human lives down the road, whether it's we always think it's going to be a strain of influenza, the flu, because historically every so often you see a flu outbreak, but it doesn't have to be. It could be any of the viruses that nature throws at us, but we're prepared.
Yeah, I think that's incredible, and especially being able. I mean, I think that speaks volumes too of your history with working with so many multiple different county executives in Nassau. Yeah. That speaks volumes to your commitment to providing quality information towards healthcare and approach towards healthcare where what's best for the residents and not necessarily any other hidden agenda. And I think that speaks volumes to you.
Thank you. And when people say, what are you most proud of? And everybody immediately goes to COVID. We went through a lot before COVID.
Right.
I was the Commissioner of Health during Sandy. And there were a lot of public health issues in Sandy. On the barrier island of Long Beach, we lost water, we lost sewers were down, and we lost electricity, and that is a recipe for public health disaster.
Yeah.
When you don't have clean water in and dirty water out, that's, the very first thing in public health. So we went through a lot. I had 2 Republican county executives and 2 Democrat county executives, and all of them treated me respectfully. And I'm very proud that I was there through multiple transitions. I just always tried to do what was best for our residents and public health. And that's something I would still stand by today.
Yeah, and your CV now, you were speaking about your infectious disease. Can you speak to your background in terms of leading up to your time as Nassau County Health Commissioner and then from today as Catholic Health's VP?
Yeah, so by training, I was an infectious disease specialist, and I did my medical training at Winthrop, which was then Winthrop University Hospital and now owned by NYU. And I was an internal medicine resident and a chief resident there. That's where I learned a little of the administrative work, because the year I was chief resident at Winthrop in internal medicine, we had a joint commission visit. And so that naturally brings the resident leaders into the C-suite with the executives. And so I kind of got my first taste of healthcare administration and knew that I liked it. But I went on and I did a fellowship in infectious disease and did some work. And I had an interest in HIV as an infectious disease specialist. Thought it was a fascinating virus, the way it evolved from this unknown killer to something we recognize, to something that killed, unfortunately, millions of people, to now something that we haven't cured, but most people we can treat relatively comfortably, so that they can live just about a normal life by taking the medication as those who don't have it. And that all happened in less than one generation, less than 30 years. I just always found that interesting. And some of my colleagues prefer the heart and some prefer the gastrointestinal system. I just found the evolution of microbes to be fascinating. Even COVID, devastating as it is, incredibly interesting from a scientific perspective. And to me, other people are going to think I'm nuts, but yeah. that's how I viewed it. And through my HIV work, I'd gotten a grant to do some work screening people at Winthrop's ER at the time after I finished my fellowship. And the then Commissioner of Health was Dr. Maria Carney, and she called me up and she said, "You're that young HIV infectious disease doctor." I said, "Yes." She said, "I need a favor." And I said, "Oh," and my wife's sitting next to me, and she said, "Well, say yes." And I said, "I haven't heard the favor yet." She said, "It doesn't matter. The Commissioner of Health that you just randomly called you and needs a favor, you're going to do it." And to make it a short story, she asked me to sit with her on the Ryan White Planning Council for Long Island, which brings money to the region for people who had HIV and AIDS with no other way to pay for their care. And they needed a doctor to sit on the council. And so I agreed to do it. And she said, "It's a lot of money to the region, but you're going to do a lot of work. It's not all that much fun, but you'll get to meet me." And so that's exactly how it was. I was reviewing grant proposals and scoring grant proposals.
Exhilarating stuff.
Oh, no pay, purely voluntary, on top of a long day of work to begin with. But I got to know her. And a year or two later, and by now we had become friendlier, and she said, "I need another favor. Can you do a presentation on every few years a doctor needs to do?" So I did a PowerPoint for the group, and that's my wheelhouse. I like to teach, and I like the science of it all. And she said, "I wish I could hire you as my deputy commissioner, my chief deputy." And H1N1 had started, so there was money. She said, "I wish I could hire you as my deputy. Help me manage H1N1." And my contract where I was expiring, and I couldn't pass up that opportunity. So that's how I became the deputy commissioner. And I have a master's degree in public health, which served me well through, especially the most recent years.
Of course.
And a couple of years later, Dr. Carney got a great opportunity, and where she's still at Northwell Health, as the chief of geriatrics and palliative medicine for the system. That's a wonderful opportunity, and her passion. And there I was, and by then the administration had known me, and I became the Commissioner of Health. And 2 terms were done this summer, and I, in my mind, had decided I've worked a lot around the clock, and there wasn't one meal that I could go out with my wife and my phone wouldn't ring, or a job would. She was tired, my kids were tired, they were tired of me getting recognized in the supermarket in the middle of the night. And I just thought of what my next stop would be, and I spoke to some of the hospital leaders around, and I was very flattered for the interest that many of them showed. But Dr. O'Shaughnessy had become the new CEO at Catholic Health, and he had been the chief medical officer there, and we had done some work together. When I was doing some policy work, I had asked all the leaders of the hospital systems to come to the health department to talk about recreational marijuana and get their flavor on it. He was a partner there, and he's a vibrant, visionary leader. And he recognized that going forward, hospitals are it's no longer a business model that works out for hospitals to just fill up the building. You would think in most businesses you want as much business as you can get, but the way contracts are being paid out for caring for patients, the way penalties are occurring from the federal government for unnecessary admissions and readmissions, especially if you send the patient home with some diseases and they come back within 30 days, hospitals pay fines. You really need a strategy to switch from sick care, where we care for people when they get to the hospital, to well care, to keep them out of the hospital. And now there's financial incentives, and it's humane to try and help people be healthy. And so Dr. O'Shaughnessy understood this and saw an opportunity for me to help bring this to the Catholic health system. And for me, it was a chance to build something with the support of a new CEO and vibrant leadership, and I couldn't pass it up. So when my term was ending, I gave notice that I'd be leaving government life and doing something new for myself, and it's been wonderful for my family, and I'm very happy and excited, and this great opportunity for me to continue the work that I was doing as the health commissioner with, a corporate hospital backing and full support. So that's where I am now.
I think that's what I'm so excited because I want to talk to you, Dr. Larry, about really the future of healthcare, where we're going, what is the current situation today, and how do we provide where it's a focus on preventative treatment? Because something when I was in the assembly, this was something I was so passionate about in the sense of providing for that preventative treatment that focuses on limiting the amount of people who are going into the hospitals. And so many people have this conception, and correct me if I'm wrong, but so many people have this conception in the public that hospitals, all they want to do is just crowd it, bill it, and then keep billing and have you coming back and more billing, and all it is billing, as opposed to focusing on treatment and providing what's best for the patients. And I just want to hear your thoughts, a sense of what's this current structure of the hospital systems on Long Island for Catholic Health, and where's the future? Where are we going? Like, what can we do to change and provide for that focus on treatment?
And I think you're right. That is a misperception, but there isn't a thing anymore of just bill, because there are insurance contracts that predetermine what hospitals are going to be paid, and they're not going to repay for the same thing twice. Medicare and Medicaid, actually, especially Medicare, there are penalties. And for Medicare, there are 6 diagnoses that if somebody comes back within 30 days after that diagnosis, not only can you not bill again, but they fine you. You pay the federal government because you didn't, in theory, provide enough outpatient care or support to keep the patient out of the hospital. And then there's a whole segment on Long Island of people who are uninsured. You can bill all you want, but if somebody doesn't have the money to pay the bill, they're not paying the bill. So the concept, what you described, I think is a common belief in the public that hospitals just want to bill. But that's not what the financial future is for hospitals. The future is getting rewarded for providing good care. And it's a very simple concept. Treat people right, keep them healthy, and that's where the higher paid contract rewards are. And so the model is now an outcome-based model, and hospitals benefit from doing right by their patients and making sure that they're cared for even after they leave. So we're putting together a whole bunch of programs and addressing what we call the social determinants of health. So
before we get into that, let's break down
Yeah.
inpatient versus outpatient.
Sure.
What's the difference for the average person right now?
Everything you do outpatient is much, 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 much less expensive. Everything you do inpatient is much, much, much more expensive.
So what are examples of outpatient?
So let's make it very simple. A young mom has a child or a young dad has a child who's febrile and tugging on their ear. Well, that's a classic ear infection. If they don't know what to do and they go to the nearest emergency room, they probably won't get admitted. But the point I'm making is they went to the hospital. That bills thousands and thousands and thousands of dollars.
Just going.
Just walking through the door, you're already into four figures. If they went to a supportive clinic like a federally qualified health center or a pediatrician's office, that's a $50 visit.
What's a federally qualified health center?
So federally qualified health centers are designated buildings that are funded at an especially better rate to see patients who are uninsured or are Medicaid recipients. Because if you say, we don't want people going to the hospital unless it's necessary. Of course, if you're having chest pain, we want you going to the hospital. So we're not saying nobody should go to the hospital, but those that can be dealt with outside of a hospital, we want them to be dealt with outside. But if you say to people, don't come to the hospital unless you're emergently ill, they need to have an alternative. So part of this is teaching the public how to get health care outside of the hospital. And if we say to this young parent, if your child has an ear infection, don't come to the hospital, then they're going to want to know where to go. So implementing a network of outpatient options, of triage. Some places use telehealth, for an example. Maybe before you go anywhere, go online to this website and talk to us, or make a phone call to us. And we're making sure that we're going to have Spanish speakers at our...
all through Catholic Health.
Yeah, we're working on this all throughout the system, new initiatives to make sure that anybody who engages our system gets appropriate care. And when possible, if we can triage them and set them up somewhere in our system or even not in our system. And one of our federally qualified healthcare partners, for example, if they live in a place where we're not, but this federally qualified clinic is, that's what's best for them, to go to their local provider and make that the place that they know, this is where I go when I need health care. The reflex for many people is to go to the emergency room. This is not a Catholic health issue, it's a national issue. And we're trying to change that. It's the culture of the nation as it involves healthcare, and there's massive incentive financially to keep people out of the emergency rooms who don't belong there, and it's better for them. It's better for them. Hospitals are places of the sickest, most vulnerable people. If you can avoid being there, you don't want to be there. But again, there has to be alternatives. So we're working on a network of partners. We have now over 2,500 affiliated doctors with our system on Long Island. So numbers are growing. We want to make sure we can provide at Catholic Health the services that any of our
so that's where patients can now go, of the 2,500. Patients can now go to those primary care physicians. Patients can go to all those different specialists per se. Correct. That's
Correct.
where
And
that would be all outpatient.
Correct. And we have a central referral line that anybody can call and find out where is there. I live in, put whatever town you want in Long Island, from Valley Stream to the Hamptons to Riverhead, anywhere. I live here and I need, my sinuses have been bothering me. I need an ENT doctor.
Right.
And they can call up and we can help them make that appointment so they don't have to come to the emergency
Can it be
room.
online too?
Yes, we have you can look at on our website. There's the online list of where people practice, which hospitals they're affiliated with. You can do it by location, you can do it by name, alphabetically. Maybe you have a friend who liked their doctor, you want to read about them, you could go online and look into and see where they are. So again, if we can help people stay out of the hospital, that's a win-win for everybody. But we have to make sure that infrastructure is in place, and it's a big part of the work that I'm doing. Very grateful to our partners who are willing to see patients, and people shouldn't think that that our hospitals are going to go out of business. There's always going to be enough very ill patients to keep the hospitals going appropriately, and that's the key. We get paid. Not just to bill, we get paid to bill appropriately for treating disease appropriately, and we're very proud of the work our hospitals do on the unfortunate times that people need them.
What's kind of some of the infrastructure that you're looking to build out now in the forthcoming year in 23, but then also 24, 25, and beyond? Where is it going now, the future of healthcare for long? Because we have the inpatient, outpatient distinguished with in hospitals, inpatient, out. All these alternatives are the outpatient with the 2,500 physicians, another federally qualified health center. But now you were talking about this outcome determinative model. Can you
Social determinant
model? Can you elaborate on that?
Yes. So many people believe if I have a good doctor and a good hospital, I'm healthy. The fact is, between 80 and 90% of a person's health outcomes have nothing to do with their health providers. Once they've gotten to their health provider or the hospital, it's too late. So what does determine if people are healthy or not? The environment they live in, the water that they drink, the air that they breathe, their personal habits. Do they smoke? Do they exercise? Are they overweight? The community that they live in, are there places to walk and get exercise? Are there sidewalks that are safe for kids to walk to school? The various factors which determine health outcomes that are not related to clinical care are called the social determinants. And what were social determinants of health? Some people call them social drivers of health. Socioeconomics is a part of it. People who are poor as a whole have worse outcomes than people that are rich, because people that are rich can afford to eat healthier, can afford the fruits and vegetables. And very often in neighborhoods where people are less affluent, the supermarket might not have. There might not be a supermarket. They call that a food desert. Or there might not be access to nutritious, healthy food for children. So then you get a generation of kids who've grown up on junk food and soda that's cheap. And kids love soda, but soda probably costs about half of what milk costs. So somebody on a very limited budget and knows the kids are going to drink it, I could understand why they would do that. Then we deal with a generation of because people can't afford the healthier product, you see higher rates of childhood obesity in socioeconomically disadvantaged populations.
And we're seeing an increase among childhood obesity, correct, over these past decade?
For the past 30 or 40 years, since basically the 70s, obesity has just exploded.
Just gradually inclined, or a huge explosion?
It was very rare in the 70s. Now it's very common for childhood and adult obesity. So
why is that?
I think there's a lot of reasons. There's so much access to junk food. There's so much to do in the house now, whether it's video games or TV.
Electronics.
When I was a kid, I was born in the early 70s. When I was 8, 10, 12 years old, we were never in the house.
Right.
Even on a cold day, we were outside, and as lousy a football player as I was in the street trying to catch the ball.
You weren't at Penn State? You didn't?
No. My daughter's there, not me. But right. But exactly. And we were outside, and we were riding bikes, and we were walking to our neighbor's house to play. Then the video game era started, and then social media and the internet. And kids today, very often, it just has so much to do with a combination of being very stagnant and having access to so much processed and junk food so easily, and it's so inexpensive. So it's multifactorial, but it's the other thing is the size of food has grown dramatically. If you look back at what restaurants used to serve 50 years ago, the plates were half the size that they are now. So even if you go out to a nice restaurant, I was at, we have incredible Italian food here on Long Island.
Delicious.
I love it. I can't get enough of it. But many of them, you order a plate, and it's the size of this table.
Oh.
And I used to try. And finish. Now I've lost some weight, so I go halfway and stop. But we're just offering so much more food than we used to.
Yeah. I'm also wondering with children, is it the lack of exercise incorporated in schools now? Because I remember years ago, gym class, I used to have the Presidential Physical Fitness Award. That was a big thing in elementary school. And beyond that, it was pushing that different athleticism, or at least engagement in that exercise. Are we seeing a reduction in that over the years? Is there something that maybe the hospitals can play in bringing that back to restore that type of exercise or athletic? What are your thoughts on that?
Well, I don't know specifically if there's less gym now than there was in the past, but 1 hour of gym class 2 or 3 days a week is probably not enough to overcome all of the other factors and the rest of the day. I know at Catholic Health, athletics is very important, and some of our hospitals have worked with our Catholic high schools to do heart screening for athletes. You've heard too often about young kids, high school, college kids who have a heart arrhythmia while playing football or basketball or baseball or whatever, and we don't want that to happen. So we are doing very active screening to make sure that our athletes in our Catholic high schools are healthy and don't have an underlying heart issue. It's a program that we're very proud of. I think that all of this, you ask what hospitals can do. I think all of this is about just educating our public. And part of this movement to keep people out of the hospital to well care is about educating them and making opportunities for people to learn about their health and participate about their health. And one thing we don't want to do, we don't want to be a hospital system that tells people all the great things we're doing for them. We want patients to participate with us in their own care, because it's not our outcome that's being measured, it's the patient's outcomes that are being measured. And so getting patients to eat a little better, exercise a little bit, just come for preventive care, get their screenings. And during COVID, a lot of people stopped going for their colonoscopies and their mammograms. Colon cancer is a disease that, with the rare exception of a genetic, unfortunate genetic variant that hits somebody very young, really, people who are screened are not going to die from colon cancer. It takes upwards of 20 years for that colon cancer to develop to a point where it can kill you. That's a 20-year window that one colonoscopy would totally cure it and save your life. And so,
what would you say with that said? Now, a lot of people aren't familiar with the ages of when should they have these screenings? Like at what age? With which gender? Male, females? When should they go for a mammogram or a breast screening or prostate screening or colon screening? Like, do you know? Can you speak to that?
Yeah. So I can, but I'm going to give a much simpler answer to that.
Okay.
There's one thing that everybody should do, and that's every year go to your primary care doctor. They're responsible, or the primary care office, if it's a PA or a nurse practitioner that sees you, whatever. That primary care provider is responsible for keeping you in line with your screenings. To say to you, you turned 45 this year, let's make it up, and there's new guidance that colonoscopies are required at 45 and above. So I'm going to set you up with an appointment. Do you have a gastroenterologist who you know or like? No? Okay. Where do you live? I live in, I don't know, Valley Stream. Here's a gastroenterologist that I know in Valley Stream. Make sure you go for this. It's very important. So primary care visits are once a year for everybody.
Okay.
Across the board. It's hard for people to stay up with, and the guidance changes. Colonoscopies recently shifted again down to 45 years old. Mammograms have shifted over the years. But your primary care doctor, it's once a year, every year from the time you turn 18, and they are responsible and very good at keeping you in line with screening. So rather than tell people this and this and this, just go to your doctor who knows you once a year, and they will keep you in line with all the screenings. And
now, but what if you don't have a primary care physician?
Reach out to us at Catholic Health or whatever your healthcare system that you prefer is. We would love for you to use Catholic Health. But look, I was the Commissioner of Health in Nassau, and I think all of our hospitals are excellent. And I wouldn't just say that. We have great healthcare. Long Island is great, world-class healthcare. And reach out. Call the central service line and say, I'm looking for a primary care doctor. I don't have somebody. And if you're uninsured or underinsured, reach out to the federally qualified health centers. There's Sun River, 9 of them in Suffolk County, and there are 2 federally qualified health centers which make up about 7 or 8 sites all throughout Nassau. So that's 16 of these locations that if you have no insurance or you're underinsured, they're designated for you, and they've been invested in. They're nice places. They're good facilities. It's not the perception of I'm not going to the public clinic. That's an old, antiquated thought. These were built to make sure that people who are underinsured or uninsured have an equal opportunity at positive health outcomes. So we could even send you to them. There's on Long Island, and in Suffolk, it's Sun River. In Nassau, there's two. There's Harmony Care, which used to be the Long Island Federally Qualified Health Center. They have 5 or 6 clinical sites and a couple in high schools. And then there's the Charles Evans Center out of Bethpage and Hopog and Glen Cove. So they actually cross over.
Okay.
Between Harmony's 5 or 6 sites, Charles Evans 3 sites, and Sun River's 9 sites, there are clinics that anybody can go to all throughout Long Island. But of course, Catholic Health would be happy to guide you and take you through the process.
What about with the insurance? So many people who have insurance, you have so many. These guys don't take you. These do take you. How much is going to be costing there? Who's going to who? This is out of network, in network, things like that. So in terms of would they be able to identify? Oh, this is my insurance. So who falls under that penumbra? That's in network.
Yes. So there's different ways you can go about doing it.
Okay.
One, you could reach out to your insurance company directly, and they will tell you what you're entitled to, what your copays are. And this can be difficult for people to understand. I have insurance. Why do I have copays and deductibles? Yeah. It's the same with car. If you got into a car accident, there's copays and deductibles. Even if you had something break down and you had insurance, you might be responsible for some of it. You can reach out to the provider and say, I need a colonoscopy and you were recommended to me, but I have so-and-so insurance. What will the charge to me be? And they might say, well, we would take your insurance, but I don't know if the hospital will call the hospital. So yes, you have to do a little bit of work to protect yourself, but if you're buying a colonoscopy for yourself, and I'm using that to help people think of themselves not as patients who are just vulnerable, but I want people to think of themselves as strong, knowledgeable customers. The same way when you're going to get a colonoscopy, it's no different than if you're going to buy a car. You're going to do your research and your due diligence. You should do the same for your own health care. And it's okay to ask, I have this insurance, do you take it? And what will it be? And if not, what are my alternatives? And certainly if somebody were to call us, we would talk them through it. And the last thing we would want is somebody to come for care with which they can't afford or which is going to cause bankruptcy for them. That's not going to help their health care in the future, and it's not what our mission is. One of Catholic Health's a mission of mercy, so it's the finances. Every hospital has to keep the doors open, but it really is important to us to help, especially the underserved, the underprivileged. But I would agree that navigating this, it sounds daunting. It sounds complicated.
Yeah, that's the average person, right? If they have 2 children, if they have 4 children, big family, work, house, and it's like, I know I have to take care of myself, but I'm trying to find out where or how and when. I got to pick up the phone, and I got to be put on hold, and then wait again. Oh, we don't take it. Click. And then I got to go on. Yeah. I got to search the internet for the next one. Yeah. I'm just wondering if there's a way that we can, the future technology that we have from the future healthcare, where is there going to be now more technologically savvy where you can just simply put in like the insurance and then it just drop down in the sense of all those different players that take that insurance with the bios, background. I can see the CV of each of the doctors, do my own investigations, but allow it to make it more easier and convenient for someone who now the kids are put to bed. It's 8 o'clock, 9 o'clock. And now you're finally in the bed and you're like, okay, let me do my research and get it done.
So I know that my own insurance company has a provider list. I can go on. I don't even have to log in. I don't even have to be a member. You can go to the website and say, who are the providers that accept this insurance? And you could do it alphabetically or geographically. I know that if you go on to Catholic Health site, for example, and put in our provider network under the doctor's name. It shows which insurances they take.
Okay.
So this is one of those examples where I think the internet and technology is going to make it easier and easier compared to back when you had to make a phone call every time.
Right. It's exhausting. And
Yeah.
and then also the times that they're available are not the times that I'm available.
Right.
So how am I going to make the calls when it's only between 9 and 5 or
Right.
something like that?
Well, the nice thing about these internet sites, they're up 24/7.
yeah.
Doesn't matter where you are or when you know. I want to know where to find, and you can do it by specialty too. You're pregnant, I need an obstetrician, put in obstetrics, and the names pop up. And the geography and the insurance. So I think that technology is making that easier. But to your point, I think healthcare had to start making it easier. And I also think it's helpful for patients when possible. I support them advocating for themselves and being good shoppers. And we want to help them make the right decision. And, you know, the thing that's really important in healthcare is, especially now that things have changed where hospitals, as I said before, there's an incentive, an important financial incentive beyond the humane part of wanting patients to do well. There's a financial incentive that hospitals get paid for better outcomes. So everybody wants the same thing. The patient wants the better outcome because they feel better and they're not sick. And the hospital wants the better outcome because it helps their bottom line and their reputation. And so this is one of those areas where when we can help patients make the proper decision, it's a win-win.
What about working in tandem with pharmacies and providing prescriptions and assistance to those who were treated and now following treatment that could have continuous renewals or refills on the prescription? They could be provided. They could get updates. Is that in place at this time, or is it working towards Catholic Health working towards that, or what's your thoughts?
I think pharmacy is one of those places where we have an opportunity to use technology to help us. Pharmacy has changed. My father was a pharmacist, and he was in the drugstore filling prescriptions, and I remember being a kid there. I loved the days in the summer when I'd hang out with him, and I remember people coming in, and I remember a person saying, I have this and this and this. What do you recommend for me? And he said, I recommend you go see the doctor. Now, today, pharmacists graduate 6 years with a PharmD, a doctorate in pharmacy degree, and they're a much more active part of a person's healthcare team. And so the role has changed and technology has changed. And to your point, if somebody leaves a hospital following an admission and they need to take a medication, and there's any barrier to that medication, whether it be they couldn't afford the medication, they didn't have transportation to get to the pharmacy, they ran out and didn't know how to get more, we can come the drug was making them not feel so good, so they stopped taking it. I can make a whole list of reasons why people don't take it. They're going to end up back in the hospital.
Right.
And we're back in that scenario where we get fined because they came back with the same diagnosis. So, and this is for all hospitals. So it behooves us to help people take their medication. And I think this goes back to the social determinants of health. Think about why the reasons I just gave. They couldn't afford it. Money, that's a social determinant of health. They couldn't get to the pharmacy. Transportation, that's a social determinant of health. All of these, this is what I'm talking about, impacting people's health factors aside from the clinical care. And so we are putting programs in place like that. We're working at Catholic Health very closely with the Health and Welfare Council of Long Island. They're wonderful, kind of the association of all the community-based organizations on Long Island. And as of this year, the federal government, CMS, Medicare, and Medicaid is requiring hospitals, all hospitals, to start screening for 5 social determinants: food insecurity, transportation difficulty, housing. Being homeless automatically puts you at risk for worse health outcomes. Domestic violence, and the last one is utility insecurity, inability to pay your heating bills or your electricity, et cetera. All hospitals are going to have to start screening for all of those by the end of this year. It's a federal requirement now, and that's because it goes to what you were saying. We acknowledge that if somebody can't take their medication because of any of those reasons, they're going to end up back in the hospital, and then we haven't done our jobs. Very proud that Catholic Health has and this is credit to our leader, Dr. O'Shaughnessy, who says all the time, food is medicine. We launched our own food insecurity screening. We launched it in November. I wasn't here for most of the groundwork. My colleague Lisa Santaramo did most of the footwork on it, but I was here in time for when we launched it in November, where every one of our 6 emergency departments screens now everybody. It started as just adults 18 and over, but we've now changed it to everybody for food insecurity. One of the 5 categories that federal government later required us to do. So we were out in front of it. And this was at the request of Dr. O'Shaughnessy. Nobody should come to our emergency room and go home hungry to an empty house with no food. Some people end up in the emergency room just because they're hungry. And not only are they hungry, but they became weak or dizzy because they haven't eaten. And so when they come in, they don't say, I'm hungry. They say, I'm dizzy, I'm weak. And then they get a whole heart evaluation when, quite frankly, just a meal would have cured them. That's so inhumane that there are people starving, and that's why they come to the emergency room. It's terrible from a business sense on top of it. So we don't want people leaving us and going home from any of our hospitals to a home with no food, and they have no way to get food. So we do this screening. Every patient that comes into the emergency room, they're asked 2 questions, which are from the CDC, the Centers of Disease Control and Prevention, the hunger vital signs. We check clinical vital signs. We screen, for a lot of different things. We're now checking the hunger vital signs that basically addresses if people run out of food before they can afford more, or if they're afraid that they're not going to be able to have food. And if they say yes to either of the questions, we offer them a bag of food to go, which covers 2 to 3 days for 1 to 2 people, because we don't want them to be hungry. And that's a low salt diet. We don't want our food to bring them back.
That's key, low salt.
Yeah, we don't want our food to bring them back. And we offer them a social service referral, which usually a SNAP referral, because it's one thing to give somebody food for 2 to 3 days. It's another to give them a lasting resource so that they don't come back hungry. We expect to show, and other health systems have proven this, that by addressing hunger, we can cut down on unnecessary visits to our emergency room. Those visits which we're not getting paid for. There's no heart disease. There's no real disease. And so financially, while hospitals struggle, this is important. But most important, we're taking care of our residents. We're taking care of our patients. That's our mission, especially those most vulnerable.
Yeah, I think, how often are you seeing patients coming in with heart issues, or even youth coming with heart issues? I know you alluded to that earlier, and I just wanted to hear your thoughts on it. Is that a frequent occurrence? Is that have you seen an increase in that influx over the years, or something?
Heart disease?
Yeah, heart disease specifically.
Heart disease is still going to be, if not one of the most common reasons that people come to the emergency room. Now, it's not always heart disease. There are a lot of chest pain. Chest pain scares people. Chest pain is something that we say, go to the emergency room. That's not one of those, let's see you in the clinic. But very often, it's nothing to do with the heart. It could be terrible acid reflux. It could be other things.
Which is due to your diet, correct?
It can be due to your diet. It can be due to being overweight. It can be because of hiatal hernia. It could be because of bacterial infections.
Oh, okay. So
a lot of reasons.
Multitude.
But yes, for the most part, reflux is related to diet and obesity, which goes back to the social determinants before. But heart issues are between heart attacks and congestive heart failure. It's one of the more common reasons people come to the emergency room. Young people with heart arrhythmias is not common, which is what makes it scary, because when it happens on a basketball court or a football field or a baseball field, it's unexpected.
Yeah, why does that occur?
Well, people have underlying risk issues that a normal kid wouldn't see, and then something happens where they're rigorously playing, or they get hit, like that football player in Buffalo or something, and an arrhythmia occurs. And we've determined that, and an arrhythmia means the heartbeat changes, and sometimes it changes to a beat where no blood is going through the body. So you can die within minutes. So if there is an underlying issue with the heart, whether it's a valve, I'm not a cardiologist, so I don't want to, whether it's a valve or a rhythm, an arrhythmia that's underlying, sometimes our screening tests pick them up. And that could absolutely and does absolutely save lives.
And those
get them
screenings are
treated.
key.
And we're very proud of what we do in our high schools
So
with that.
yeah, so can you speak more on that? Because to me, I would think that all these screenings and whatnot should occur, frankly, in your 30s and 40s and beyond. But would that make sense for parents to take their kids for screenings at a younger age then?
I think there's more and more of a push for high school kids to get this kind of screening, especially for highly vigorous contact sports. I think if kids are playing football, kids are playing ice hockey,
Right.
Basketball, running up and down, I absolutely think it makes sense. What is the downside to just get your child screened? Even though the odds are slim, kids die every year from heart issues from sports. And it's not thousands, but even if it's two, why should two kids, 15, 16, 18, 20 years old in this country, die from something that's preventable? So,
And that's something that you've seen over the years consistently, where it's a minor amount, but those children have always there's been deaths on the fields due to these.
yeah, underlying heart risks that
Wow.
never showed themselves. So
Wow.
I think that's something that we have an opportunity. And again, it's not thousands of kids, but why should it be any when
Of course.
we have preventive screening methods? So, like I said, we're very proud of the work that we're doing in partnership with the Catholic high schools. This started before I was here. Give credit where it's due.
Yep.
But in general, I think you're hearing more and more about it. And these unfortunate incidents, like what happened to that Buffalo Bills player, I think it sheds more light on it, and more people are becoming accepting that, hey, we should do this.
So what is the future of healthcare in the next 5 years, 5-10 years, in
So-
like a nutshell?
So in a nutshell, we at Catholic Health are currently building a massive big box healthcare center in West Islip, $500 million project outside of Good Samaritan Hospital. And Dr. O'Shaughnessy, our CEO, describes it as an all-in-one center, like the big box of healthcare. But it's not an emergency room. It's not a place that you come and sit and wait for hours. It's a place that you can get comprehensive care when you need it. We'll see people quickly and then others by appointment. There's a family health center being constructed on the grounds of Mercy Hospital. Similar concept, slightly smaller. There's an outpatient center that we're building in Center Reach. What you're going to see in the next 5 years is hospitals like our system and all the others to do as much as they can to shift care to outpatient and focus on prevention and wellness rather than wait till people get sick.
Yeah.
That's what you're going to see in the next 5 years.
I think that's going to be excellent, because that's exactly what the people feel. That's what they want, and I'm glad to see that our healthcare systems are adapting to the desires of the community on Long Island. So that's going to be huge. So, Dr. Larry, this has been absolutely fantastic. I've had an absolute pleasure learning from you, talking to you, and getting to know you better. I'm sure the viewers and listeners feel the same. Thank you for your time.
Hope to come back sometime. Thank you.